Putting on the front page of Neurosurgical TV now. Just give me a minute, I'm almost ready. Okay. Oh, just 1 second. Amanda, what year are you? You're a resident?
I'm 50-year medical student.
Okay, medical student, okay.
Yeah.
Okay, very good. Okay, we're almost set, hold on. Oh, good, okay. Okay, let me introduce you. Hold on. Okay, you ready? Hi, Natara John, how you doing?
Yeah, fine. Very good
Yeah,
evening.
I'm
How are
John
you, sir?
Bennett. I'm John Bennett of Neurosurgical TV.
Yeah. Good evening, sir. Very nice.
You're in Kerala?
Yeah, I'm in Kochi in Kerala state of India.
Okay, I'm gonna let Ahmed introduce you. Okay.
Yeah, sure.
Okay, ready, Ahmed?
Okay, just a minute, sir.
Okay. Yeah, let me see if you got a lot of people, even though we didn't have.
Okay, could we start now?
Okay, let me just get set. Hold on. YouTube, where is the sign? Okay, on YouTube. Okay, very good. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett televising for Neurosurgical TV, which is in Miami. It's just really like that. Today we have the honor of having a Yemen neurosurgery grand rounds with Walter Dandy of Yemen, led by Ahmed Al Ghanemi. He's a medical student, and he'll be introducing today's esteemed speaker. Good day, Ahmed. It's all yours.
Thank you, dear John. Here's Ahmed Al Ghanemi, the president of Walter E. Dandy Surgical Student Club of Yemen. I'm also marketing officer in Abdul Rauf University of Neurosurgery, which is considered the first online academic degree in neurosurgery worldwide. I'm so honorable and pleasure to introduce Professor Natarjan, who is a consultant neurosurgeon and has a fellowship in minimally invasive and advanced brain surgery. Hi, dear Prof. Can you hear me?
Yeah. Hi.
Yes, go on.
Can I go ahead?
Yeah.
Okay.
Perfect.
So good evening, everyone. So I thank Walter E. Dandy Society and Dr. John Bennett for giving me this opportunity to present in Yemen neurosurgery rounds. So today we will have a discussion on the anatomy of the thalamus. So this lecture, it will be predominantly an visual lecture. So we will not have any descriptive lectures with multiple sentences or descriptions. So this will usually be an pictorial representation of the anatomy. So it will be an integration of anatomy, the integration of neuroanatomy and the neurophysiology coupled with the neuropathology and neuroradiology for the management of thalamic lesions. So I would first start the session with a tribute to my parent institute where I have been trained from. And I belong to the Amrita Hospital from Kochi in India, in this part of the world. So way back in 2017, I remember meeting Dr. Professor Rauf in Dandy Society meet in St. Louis University in 2017 when I was finally a resident there. So thank you very much. Once again, it was a pleasure to be a faculty now in the same forum. So for the next few minutes or so, we will have the discussion on the anatomy of the thalamus in the various subdivisions. So first about the gross anatomy. So before starting the gross anatomy of the thalamus, we'll have a brief introduction to the embryological origin of the thalamus. So the nervous system is divided into central and periphery, and the central nervous system is comprised of the brain and spinal cord. And the brain in turn is composed of the cerebrum, diencephalon, brainstem, and cerebellum. The diencephalon is composed of thalamus, hypothalamus. So our main discussion is going to be focused on the thalamus. So the diencephalon contains the thalamus, and the cavity within the thalamus is called as the third ventricle. So the diencephalon, it consists of predominantly 4 parts: the dorsal thalamus or the thalamus proper, the subthalamus or the ventral thalamus, the hypothalamus, and then the epithalamus. The epithalamus is predominantly composed of pineal gland, habenular commissures, and the posterior commissure, which constitutes the epithalamus. So then the subthalamic nucleus, this is a subthalamic nucleus, which is a continuation of the tegmentum of the midbrain. So this is the subthalamus, which is present just inferior to the thalamus. So this continues as the midbrain tegmentum. And this is the dorsal thalamus or the thalamus proper, which we will be having a detailed discussion on for the next few hours or so. The primary function of the thalamus is to relay and integrate the information, which is the relay center of the brain. It is the only sensory pathway not mediated through the thalamus is the smell. Though the smell is not relayed in the thalamus, the sense of smell, the fibers, they negotiate through the thalamus, through the amygdaloid nucleus. Through the amygdaloid nucleus, they do pass through the thalamus, but the thing is they do not relay in the thalamus. The thalamus is situated at the core of the diencephalon, and it is deep to the cerebral cortices. So that is why, so any lesions in the thalamus, it is very difficult to negotiate without producing any neurological deficits. So that is why that we need to have a detailed knowledge of the anatomy of the thalamus. So it acts as a head office for all sensory and motor inputs from all over the body. Thalamus relays and integrates all motor and sensory impulses between higher centers of the brain and peripheries. So this is a cross-section of the thalamus, a cross-section of the cerebral hemispheres, illustrating the thalamus. So in this presentation, we will be seeing in a step-by-step manner. So initially, we will have a pictorial or a line diagram representations of the thalamus. Then we will have the same thing. We will see it in the illustrations and then in the gross anatomy, and then how to read the thalamus in an MRI. So this is a line diagram where you see this is the thalamus on either side of the third ventricle. So the thalamus, it has 2 ends, the anterior or the anterior end and the posterior end, and it has 4 surfaces: superior, inferior, medial, and lateral surfaces. So there are 2 ends or poles, which is the anterior and the posterior poles. Okay, so there are 2 ends and there are 4 surfaces, that is superior, inferior, lateral, and medial surfaces. So the superior surface or the anterior pole is closely related with the foramen of Monro. So this is the lateral ventricle. This is the third ventricle. The lateral ventricle communicate with the third ventricle through the foramen of Monro. That is the interventricular foramen. Similarly, the lateral ventricle communicates with the third ventricle through the interventricular foramen on either side. So this communication, this anterior pole of the thalamus, it forms the posterior boundary for the interventricular foramen. So the superior surface of the thalamus is related to the stria terminalis and the caudate nucleus. The head of the caudate nucleus. This is the head of the caudate nucleus. The head of the caudate nucleus is separated from the superior surface of the thalamus by the band of fibers called the stria terminalis. These stria terminalis, they extend from the interventricular foramen to the temporal horn. That is the inferior horn of the lateral ventricle. So the stria terminalis, they extend from the interventricular foramen to the inferior horn of the lateral ventricle or the temporal horn of the lateral ventricle. And just behind the stria terminalis, we have the thalamostriate veins. And this is stratum zonale. So stratum zonale, it is the thin band of white matter which covers the dorsal surface of the thalamus. It is a thin band of white matter which covers the dorsal surface of the thalamus. And this on the lateral aspect, this is called as an external medullary lamina, which separates it from the reticular nucleus. So stratum zonale is just an outer thin covering of the thalamus. So we'll just look at the boxes alone. So we'll have a lot of pictures from the Netter's Atlas. So it will be a very busy picture. So just concentrate on the boxed out descriptions alone. So here we have, this is the thalamus here. This is the dorsal surface of the thalamus. So now this has been reflected. And what you see here is, this is the stria medullaris thalami. This is stria medullaris thalami, which is closely related to the medial surface of the thalamus. The stria medullaris thalami is a horizontal ridge which extends from the anterior perforated substance to the habenular commissure. So this is an horizontal band of tissue which extends from the anterior perforated substance to the habenular commissure. So this stria medullaris thalami is closely related to the medial surface of the thalamus. And the other structure which is related to the medial surface of the thalamus is the intrathalamic adhesions. So can you see here, this is an horizontal tissue which is called as the interthalamic adhesion or massa intermedia. Okay, so this acts as a connection between the two thalamic nucleus. And then is the stria terminalis, which is closely related to the supralateral boundary of the thalamus, which separates it from the caudate nucleus. So this is the head of the caudate nucleus. This is the head of the caudate nucleus, and here you have the stria terminalis. The stria terminalis is closely related with the thalamostriate vein. So this is the thalamostriate vein. So here in this side, the stria terminalis is exposed. So the superior thalamostriate vein is exposed here. So this is the axial section. So this anatomy is very, very important for planning the surgical approaches to the thalamic lesions. So the axial section, this is the axial section. So you can see here the lateral border or the lateral surfaces anatomy of the thalamus, the anatomy of the lateral surface of the thalamus. So this is the thalamus. With the thalamus is separated by a Y-shaped lamina. This is called the internal medullary lamina. And then the just lateral to the thalamus is the posterior limb of the internal capsule. So this is the posterior limb of the internal capsule. This is the posterior limb of the internal capsule. This is the genu of the internal capsule. This is the anterior limb of the internal capsule. The anterior limb of the internal capsule lies between the caudate and the lenticular nucleus. The posterior limb of internal capsule lies between the thalamus and the lenticular nucleus. This lentiform nucleus is composed of putamen and globus pallidus. Okay, you have the putamen in the laterally and globus pallidus internally. The globus pallidus intern is divided into globus pallidus internus and globus pallidus externs. So this is the lateral surface of the lateral surface anatomy of the thalamus. So this anatomy is very, very important because while accessing the thalamus through the transcortical approaches, we have to negotiate through all these vital structures. So when we negotiate with all these structures, there is every chance that the patient may develop contralateral hemiplegia or hemiparesis. So we should try our level best to avoid manipulating or negotiating through these vital structures, because it is through the posterior limb of the internal capsule, the corticospinal tracts and various other motor tracts traverses through the posterior limb of the internal capsule. So the comparison of the axial and the coronal section. So it is very, very important to understand and orient the anatomy of the internal capsule, lateral ventricle, third ventricle, and the thalamus. Okay, so it is important to orient this internal capsule, lateral ventricle, and the third ventricle. The medial surface of the thalamus is related to the lateral border of the third ventricle. So this is the third ventricle, which is a midline slit-like aperture. So the lateral border of the third ventricle is related to the medial boundary of the thalamus. So now this is another cross-sectional anatomy. So where we are seeing here, this is the caudate nucleus. So the caudate nucleus has the head. This is the head of the caudate nucleus. This is the body of the caudate nucleus, and then the tail of the caudate nucleus, which ends in the amygdaloid body. And then here you have the lentiform nucleus, which is composed of putamen and globus pallidus internus and externus. And this is the thalamus. So medially you have the thalamus, and laterally you have the lentiform nucleus. So this is the cleft for the internal capsule, where the internal capsule and the fibers of the internal capsule negotiates through this cleft of the internal capsule. So which is between the caudate, thalamus, and the lentiform nucleus. The inferior relationship of the thalamus. So here you have what is called as the hypothalamic sulcus. So this is called as the hypothalamic sulcus. So beyond the hypothalamic sulcus, you have the hypothalamus. So this forms the inferior boundary of the thalamus. So this is the hypothalamic sulcus, which separates the hypothalamus and the thalamus. And then you have the subthalamic nucleus. So now we will see about the nucleus of the thalamus. So the entire thalamus is divided by an Y-shaped lamina. The entire thalamus is divided by an Y-shaped lamina into ventral, anterior, and the medial. The anterior nucleus of the thalamus lies between the Y-shaped lamina. Okay, the anterior nucleus of the thalamus lies between the Y-shaped lamina. The one which is lateral is called as the ventral group of nucleus. So the ventral group of nucleus is composed of ventral anterior, ventral lateral, and ventral posterior. And the one which is medial is called as the medial lateral dorsal and the lateral posterior. And the one which is posterior is called as the pulvinar nucleus. It is called as the pulvinar nucleus. And the one which is medial to the Y-arm of the lamina, it is called as the midline nucleus, the medial dorsal nucleus. So these are the various nucleus of the dorsal thalamus, the ventral group and the lateral group. The ventral group, you have the ventral anterior, ventral lateral, and ventral posterior nucleus. And in the lateral group, you have the lateral dorsal and the lateral posterior nucleus and the pulvinar. And the other parts are the anterior nucleus, the intralaminar nucleus, which lies within this lamina. These are called as the centromedian parafascicular nucleus. These are called as the centromedian parafascicular nucleus. And then this is called as the metathalamus, which comprises of the medial and the lateral geniculate body. Then the connections of the thalamus. So all the sensory impulses and the motor tracts, they relay in various nucleus of the thalamus. So the sensory impulses like olfactory, they don't actually relay in the thalamus, but they actually traverses through the thalamus through the amygdaloid complex. The hearing, vision, visceral impulses, and the taste fibers through the solitary-thalamic tract, they all relay in the thalamic nucleus. So these are the ascending, that is the ascending spinothalamic tracts and the dorsal columns. So we need to know some brief anatomy about these things. So we'll skip that. So first we'll see about the ventral posterior nucleus. So the ventral posterior nucleus is a very important part because both the sensory and the motor relay happens in the ventral posterior nucleus of thalamus. So in the ventral posterior nucleus has a medial part and it also has a lateral part. The medial part of the ventral posterior nucleus, it receives fibers from the trigeminothalamic tract and solitary-thalamic tract. That is the taste fibers. So solitary-thalamic tract is the taste fibers. So this trigeminothalamic tract and the solitary-thalamic tract, they reach the medial part of the ventral posterior nucleus. The lateral part of the ventral posterior nucleus receives the medial lemniscus and the spinothalamic tracts. So these fibers, they pass through the posterior limb of the internal capsule and reach the somatosensory areas, that is area 312, through the superior thalamic radiation or superior thalamic fasciculus. The ventral lateral nucleus is still divided into anterior, medial, and posterior part. The anterior part of the ventral lateral nucleus receives fibers from the globus pallidus. The medial part of the ventrolateral nucleus receives fibers from the substantia nigra. The posterior part of the ventrolateral nucleus receives fibers from the cerebellar nuclei, vestibular nuclei, and spinal cord. So these fibers, the efferent loop from the ventrolateral nucleus goes to the premotor and the supplementar motor areas and to the area for the primary motor cortex. So this ventral posterior part of the ventrolateral nucleus, this is one of the surgical target. This is one of the surgical target to treat or ablate the ablation for the tremors in Parkinson's disease. Okay, so this posterior part of the ventrolateral nucleus is of surgical importance because this part of the ventrolateral nucleus is used for the ablation in the treatment of tremors in Parkinson's disease. And then the pulvinar nucleus. The pulvinar nucleus, it is also called as the buttocks of the thalamus. So because it is the posterior, it forms a prominent posterior part of the thalamus. So this is also called as the buttocks of the thalamus. So the pulvinar is further divided into or related as an inferior, medial, and lateral. The inferior part of the pulvinar receives direct fibers from the retina and also from the superior colliculus and pretectal areas. And finally, these fibers, they relay into the efferent loop from the pulvinar, synapses in the prefrontal and orbitofrontal, temporal lobe, and to the occipital lobe. The lateral dorsal and the lateral posterior nucleus also receive fibers from the superior colliculus. The efferent loop goes to the cingulate gyrus, parahippocampal gyrus, and to the parietal lobe. The anterior nucleus of thalamus, it receives fibers from the afferent loop is from the mammillary body. So the fibers from the fornix, they end in the mammillary body. And from the mammillary body, the fibers come to the anterior nucleus through the mammillothalamic tract. And the efferent loop of the anterior nucleus goes to the cingulate gyrus and parahippocampal gyrus. So this circuit is what is called as the Papus circuit. This is called as the Papus circuit, which is responsible for the memory. So this nucleus is primarily responsible for attention and memory. And memory, especially this nucleus, this Papus circuit is responsible for recent memory. Then the mediodorsal nucleus. The mediodorsal nucleus receives fibers. The afferent loop is from the amygdala and efferent is towards the parietal and insula and the cingulate gyrus. So this mediodorsal nucleus is responsible for controlling emotional states. So any lesion or any issue with the medial dorsal nucleus, you have a pathology what is called as Wernicke-Korsakoff syndrome. The intralaminar nuclei, it is divided into anterior and the posterior group. It receives the afferent loop is from the spinothalamic tract, the reticular formation, the superior colliculus, and cerebellar nuclei. And these intraraminar nucleus, they synapse the afferent loop. The efferent loop goes to the striatum. The striatum is composed of caudate and putamen. So this efferent loop goes from the intralaminar nuclei. They primarily go to the striatum. The striatum is composed of caudate and putamen. Actually, there are two types of striatum, a ventral striatum and a dorsal striatum. So primarily, it is the nucleus accumbens and the olfactory tubercle which forms the ventral striatum. The dorsal striatum is formed by the caudate and the putamen. So primarily, if we say striatum, it means that it is caudate and putamen, which represents the striatum. So the intralaminar nucleus has direct connections with the striatum apart from the motor and premotor complex. The midline nuclei, these are also called as the centromedian parafascicular nucleus. So the midline nucleus, they have the afferent, they receive the afferent from the noradrenergic fibers from the locus coeruleus, which is a structure in the floor of the fourth ventricle. And they also receive the serotonergic fibers from the raphe nuclei and from the reticular formation, periaqueductal gray matter, and from the hypothalamus. So the efferent loop goes to the orbitofrontal cortex and the hippocampal formation and amygdaloid complex. So these are primarily responsible for the memory and arousal. So it is said to be that these are previously considered to be part of the ascending reticular activating system, which is responsible for the arousal. So then about the metathalamus, the medial and lateral geniculate body. The medial geniculate body, the afferent, the main fibers which is negotiating through the medial geniculate body are the hearing fibers. They are the auditory fibers. So both the ascending and the descending acoustic pathways are negotiated through the medial geniculate body. So the fibers, you can remember it as E. coli MA, that is the eighth nerve, the cochlear nerve, the olivary nucleus, that is the superior olivary nucleus. Then L stands for the lateral lemniscus. So I stands for the inferior colliculus, M stands for the medial geniculate body, and A for the auditory radiation or the auditory cortex. So you remember the tracts of the fibers of the auditory pathways as E. coli MA. The lateral geniculate body is mainly concerned with the visual pathway. So all fibers concerned with the vision is negotiated through the lateral geniculate body. So the lateral geniculate body has actually 6 lamellas. It actually has 6 lamellas. So apart from the 6 laminas, so it receives fibers from the same side of the retina to layers 5 and layers 3 and 2. So 2, 3, 5 receives the ipsilateral retinal fibers, and the rest receive fibers from the contralateral retina. So then this is about the subthalamic fibers. These are the subthalamic fibers. So this is one of the most complicated and complex part of the surrounding anatomy of the thalamus, where most of the or major fibers are negotiated or traverses through this subthalamic part. So we need to have a basic understanding over this fibers. So I'll orient this picture. So this is the this is the thalamus here. This is the dorsal thalamus. This is the internal capsule, and this is the globus pallidus. So this subthalamic part is primarily concerned with fibers from the globus pallidus and the thalamus. So basically, this subthalamic part contains 2 main fibers. One is the ansa lenticularis. It starts from the globus pallidus, passes along the internal capsule. It doesn't traverse through the internal capsule. It passes along the internal capsule, and this area, just it lies medial to the subthalamic nucleus. So this is a subthalamic nucleus. This is the zona incerta. This is zona incerta. This is the subthalamic nucleus. So this ansa lenticularis passes along the internal capsule, and it goes superiorly along the medial part of the subthalamic nucleus. Similarly, this is the fasciculus lenticularis. Okay, this tract or this fiber starts from the globus pallidus. It traverses the internal capsule. Okay, it traverses the internal capsule, whereas the ansa lenticularis doesn't traverse the internal capsule. This fasciculus lenticularis traverses the internal capsule and above and medial to the subthalamic nucleus. So it lies above and medial to the subthalamic nucleus. So the entire area, the entire subthalamic area through which the various fibers pass is called as the fields of Forel. It is basically called as the fields of Forel. Okay, there is 3 fields of Forel, H, H1, and H2. So this part, this part where the fasciculus lenticularis lies between the zona incerta and the subthalamic nucleus is called as the field H2. Okay, this is called as the field H2. That is the fasciculus lenticularis lying between the zona incerta and subthalamic nucleus. So then this is a direct fiber between the globus pallidus and the subthalamic nucleus. So this is a direct fiber between the globus pallidus and the subthalamic nucleus, which is called as the subthalamic fasciculus. So then the just medial to the zona incerta and subthalamic nucleus, the ansa lenticularis and the fasciculus lenticularis, they join together, they traverse together. So this area is called as the field pre-rubral field or the field H. So along with the ansa lenticularis and the fasciculus lenticularis, you also have fibers from the red nucleus and the dentate nucleus. So that is the dentatothalamic fibers and the rubrothalamic fibers also travels along with the ansa lenticularis and the fasciculus lenticularis in the pre-rubral field H. And then the thalamic fasciculus passes to the dorsal thalamus. This is called the one which is between the zona incerta and the thalamus is what is called as the field H1. So we have field H where all the four tracts traverses through it, just medial to the subthalamic nucleus, and the field H1 which lies between the zona incerta and the thalamus, and then is the field H2 where the fasciculus lenticularis lies between the zona incerta and the subthalamic nucleus. So this fibers and the orientation of various nucleus, the various gray matters or the various nucleus is very, very pivotal, because this anatomy is very important in the ablative procedures, especially in deep brain stimulations. Because this subthalamic nucleus, it forms one of the target. The subthalamic nucleus is one of the target for the treatment of tremors in Parkinson's disease. So this is the anatomy which we have so far seen. So this is a coronal section. Just concentrate on the box alone. So from medial to lateral. So this is the third ventricle. This is the thalamus. The medial wall of the thalamus is related to the lateral wall of the third ventricle. The thalamus is divided into various nucleus by the Y-shaped lamina. And this is the lateral surface of the thalamus. The lateral surface of the thalamus is related to the posterior limb of the internal capsule. Then the lentiform nucleus. The lentiform nucleus contains the putamen and the globus pallidus internus. So now what all we have seen, we shall now see it as an animated or an illustrations of the connections and the nucleus. So this is the anterior pole of the thalamus, and this is the foramen of Monro. This is the foramen of Monro, or the interventricular foramen. So the anterior pole of the thalamus forms the posterior boundary, or it forms the posterior boundary of the interventricular foramen. And it is also related to the choroid plexus. The interventricular foramen of Monro also has 5 important veins. So there are 5 veins which join to form the thalamostriate vein and the internal cerebral vein. It can be called with the mnemonics called as tracts. That is the superior striate vein. The T stands for the thalamostriate vein, A for the anterior terminal vein, C for the choroidal vein, and S for the septal vein. So these 5 veins join to form the internal cerebral vein. So this is the third ventricle which forms the medial relationship for the thalamus. The dorsal relationship of the thalamus. So this is the pulvinar. This is the dorsal surface. So the dorsal surface is primarily related to the stria terminalis, choroid plexus of third ventricle. This is stria terminalis, the choroid plexus of the third ventricle, the body of the fornix, the internal cerebral vein, caudate nucleus, the reticular nucleus, and posterior limb of the internal capsule. So these are the dorsal relationship of the thalamus. So now you can see this is the internal cerebral vein. which forms the dorsomedial part, which is related to the dorsomedial part of the thalamus. The internal cerebral vein is related to the dorsomedial part of the thalamus. This is the superior thalamostriate vein, which is related to the dorsolateral part of the thalamus. So the superior thalamostriate veins is related to the dorsolateral part of the thalamus, and the internal cerebral vein is related to the dorsomedial part of the thalamus. So the head, this is the head of the caudate nucleus, body, and the tail of the caudate nucleus, which actually wraps up the thalamus. So the head of the caudate nucleus is related to the dorsal surface of the thalamus. It is separated from the dorsal surface of the thalamus by the stria terminalis, which contains the superior thalamostriate vein. So this external medullary lamina, previously we have seen that it is the dorsal nucleus, the dorsal surface of the thalamus is covered by a thin band of white matter, which is called as the stratum zonale. And the lateral aspect, it is covered by an external medullary lamina, which separates from the reticular nucleus of the thalamus. So just to reinforce on the lateral relationship of the thalamus, so this relationship I'll be repeating in many slides to come, because this is the most important part in the relationship of the thalamus. So the posterior limb of the internal capsule, then the globus pallidus internus, globus pallidus externus, and then the putamen, which forms the lentiform nucleus. The posterior relationship, it is that is mainly the pulvinar, which is called as the buttock of the thalamus. It is related to the pineal, to the epithalamus, that is the pineal gland, posterior commissure, and the habenular commissure. So basically, and inferior to the pulvinar lies the medial geniculate body and the lateral geniculate body, just lateral to the corpora quadrigemina. Corpora quadrigemina is composed of two superior colliculus and the two inferior colliculus. So the pulvinar is inferiorly related to the medial geniculate body and the lateral geniculate body, which lies just lateral to the corpora quadrigemina. And this pulvinar nucleus, it lies deep to the splenium of corpus callosum. This pulvinar nucleus, it lies deep to the splenium of corpus callosum. Then the inferior relationship of the thalamus, it is related to the hypothalamic sulcus. So antero-inferiorly, it's related to the hypothalamus, and straight inferiorly, it is related to the cerebral peduncle and the cerebral aqueductal sylvius. So the anterior nucleus, which lies between the Y limb of the lamina. So this is this has an afferent loop from the mammillothalamic tract. So these are what we have seen, which now we will see as an illustration. So it is the afferent loop is the mammillothalamic tract, and the afferent loop is to the cingulate gyrus. This forms the Papus circuit, which is responsible for recent memory. Then the ventral nucleus. So the ventral nucleus is divided into ventral anterior, ventral lateral, and ventral posterior. The ventral anterior and ventral lateral nucleus is responsible for the motor relays. The motor relays happen in ventral anterior and ventral lateral. In the ventral posterior, the sensory relay happens in the ventral posterior nucleus. The ventral anterior nucleus, the afferent loop is from the globus pallidus, substantia nigra, and the efferent loop is towards the orbital cortex and prefrontal cortex. The ventral lateral nucleus, the afferent loop is from the dentate nucleus of cerebellum, substantia nigra, and globus pallidus. The efferent loop is to the primary motor and the supplementary motor cortex, area 4 and area 6 Brodmann. The ventral posteromedial nucleus, the medial part of the body, the head and neck, the sensations from the head and neck is primarily through the ventral posteromedial nucleus. That is the trigeminothalamic tract, the solitariothalamic tract, the taste fibers. These are all negotiated through the ventral posteromedial nucleus of thalamus, and the efferent loop goes to the area 312. The ventral posterolateral nucleus of the thalamus, the spinothalamic tracts, the spinothalamic tract and the medial lemniscus, they primarily relay at the ventral posterolateral nucleus of the thalamus, and the efferent loop is to the area 312. Then the pulvinar nucleus, it receives fibers from the medial and lateral geniculate body. They play a role in the integration of visual, auditory, and somatic input. So the lesions of the pulmonary nucleus, they primarily result in visual, spatial, perceptual, and language disturbances, which is called as sensory aphasia and hemispatial neglect. The medial geniculate nucleus and the lateral geniculate nucleus. So these are the prominents just inferior to the pulvinar nucleus of the thalamus. So the lateral geniculate nucleus, primarily the afferent lobe is from the optic tract and the efferent is towards the auditory visual cortex area 17. And the medial geniculate nucleus, the afferent is from the inferior colliculus or the brachium of the inferior colliculus, and the efferent lobe is towards the auditory cortex. So this is the internal medullary lamina, and the intralaminar nucleus lies within here, which is also called as the centromedian parafascicular nucleus. And this is the reticular nucleus. The primary function of the reticular nucleus, these reticular nucleus, they receive the afferent loop, and the efferent loop is within the thalamus. So far, so long, we have been seeing the thalamic nucleus having an efferent loop from various parts of the brain and body, and the efferent loop is towards the cerebral cortex, whereas the reticular nucleus has the afferent loop and the efferent loop within the thalamus only. So the connections is confined and restricted to the thalamus, and the output from the reticular nucleus is primarily inhibited. And the efferent loop is within the thalamus. So far, so long, we have seen the thalamic nucleus having an efferent loop from various parts of the brain and body, and the efferent loop is towards the cerebral cortex, whereas the reticular nucleus has the afferent loop and the.
I guess there is a noise. Hi, John, can you hear me?
I hear something now.
Yeah, I guess there is a noise, maybe from.
Okay, I fixed it. I'm sorry.
Okay. You can go ahead, sir.
Okay. So then is the centromedian nucleus. So the centromedian nucleus, the afferent loop is mainly from the globus pallidus, putamen, and the caudate, which is called as the striatum, and the efferent loop is to the motor cortex. So this anatomy is very, very important because the centromedian nucleus is one of the primary target, or it is one of the primary target for ablation in controlling tics in Tourette syndrome. It is very, very important in controlling the tics, the motor tics in Tourette syndrome. So the target for ablation is the centromedian nucleus of the thalamus. Then the dorsomedial nucleus. So the afferent lobe is from the amygdala and substantia nigra, and the efferent lobe is to area 9 and 10, that is the prefrontal cortex. So the mediodorsal nucleus, they play a role in the expression of affect, emotion, and behavior, the primary limbic function. So any pathologies here will result in Wernicke-Korsakoff syndrome. So to summarize the nucleus, these are the various nucleus which we have seen. The one important thing in the surgical aspect, which we would like to say is this is a gross anatomical part, but one part which I have not told is the ventral intermediate nucleus. So in the surgical classification of the thalamus, we also have something called as ventral intermediate nucleus of thalamus. So this ventral intermediate nucleus of thalamus, which is also a part of the ventral posterior nucleus of the thalamus, it is a site for ablation in the treatment of essential tremors. Okay, it is a site for ablation in the treatment for essential tremors. So after having an understanding over the illustrations, now we will get into the cadaveric dissections. So the microneuroanatomy is never complete without roton. So we'll also see some roton's cadaveric illustrations. So now we will have a lot of pictures with a lot of explanations or a lot of markings. So just concentrate on the markings which I have made with the boxes. Okay, so this is the sagittal section. What you see here is the medial cerebral hemisphere, the medial surface of the cerebral hemisphere. And this is the thalamic nucleus. This is the thalamus. And here is the foramen of Munro, the interventricular foramen, which you can clearly see the thalamus forms the anterior pole of the thalamus forms the posterior boundary for the foramen of Munro. And here is the lateral, the metathalamus, the lateral geniculate body. This is the lateral geniculate body. And this is the posterior surface of thalamus. This is the pulvinar nucleus of the thalamus. And here is the caudate head, the head of the caudate nucleus, the body of the caudate nucleus. And this is the pulvinar part of the thalamus. And here you can clearly see the relationship of the internal capsule with the thalamus. This is the anterior limb of the internal capsule, genu, and the posterior limb of the internal capsule. And this is the pulvinar. And the other two parts of the internal capsule is the retrolentiform part of the internal capsule and the sublentiform part of the internal capsule. The sublentiform part of the internal capsule carries the optic radiation, and the laterolentiform part of the internal capsule carries the auditory radiation. So this is the coronal section again. And what you see here, this is the lateral ventricle, and this is the dorsal surface of the thalamus. This is the thalamus. So now we will zoom into this anatomy of the. So now we have just zoomed into this part. So you can clearly see the thalamus again, the globus pallidus internus and the globus pallidus externus, and this is the putamen. This is the lateral ventricle, and this is the third ventricle. This is the third ventricle. And now you can clearly see the this is the caudate, this is the lateral ventricle from medial to lateral. This is the lateral ventricle, and this is the caudate nucleus. The anterior limb of the internal capsule lies between the caudate head of the caudate nucleus and the lentiform nucleus. And here is the genu of the internal capsule. The posterior limb of the internal capsule lies between the thalamus medially and the lentiform nucleus laterally. So now the ventricles, the lateral ventricles, the relationship and association of the lateral ventricle with the thalamus is to be known, because the thalamus forms almost all of the boundaries of the lateral ventricle. It is related to it superiorly, posteriorly, and inferiorly to the lateral ventricle. So now this is the axial section. This is the thalamus, and this is the lateral ventricle. So you can now we'll get into it. Now what you see here is the foramen of Munro. This is the thalamus, and here is the fornices. And this is the choroid plexus, which lies between, the choroid plexus lies in the choroidal fissure, which lies between the thalamus laterally and medially is the fornix. Once again, here this is the choroid plexus, which lies between the thalamus and the body of the fornix. So now we will get into this part of the anatomy. So now we'll focus on this part alone. Now we have zoomed into it. So what we see here is this is the thalamus, and here is the thalamus striate vein. This is the thalamus striate vein, and here is the choroidal plexus lying in the choroidal fissure. So you can clearly see the relationship of the thalamus with the lateral ventricle. The thalamus, so this is the frontal horn of the lateral ventricle. This is the body of the lateral ventricle. This is the atrium of the lateral ventricle, and this is the inferior or the temporal horn of the lateral ventricle, which is, so this section will correspondingly see here. So what you are seeing is the body of the lateral ventricle, where the thalamus forms a floor for the body of the lateral ventricle. And similarly, in the temporal horn or the inferior horn of the lateral ventricle, the thalamus, it constitutes the medial boundary for the temporal horn of the lateral ventricle. So now what you see here is the intrathalamic adhesion. So this is related to the medial boundary of the thalamus. This is the intrathalamic adhesion, or otherwise called as massa intermedia. Massa intermedia. So how to read thalamus in an MRI? So in the left-hand side, what you see here is the, in the right-hand side, what you see here is an illustrated anatomy, and the same thing in the various sequences in MRI has been shown here. So the thalamus lies here. This is the lateral ventricle, and the thalamus is visualized here. This is the thalamus. What you see here is the axial section. The corresponding, what you see above this picture shows the cuts of the MRI. So at this level of the brain, you see these axial sections. So once again, so you can see the thalamus at this level, which is related to the just lateral to the third ventricle. And you can clearly see the anatomy with the internal capsule here. Here you can clearly see that. So this is the anterior limb of the internal capsule. This is the genu of the internal capsule. This is the posterior limb of the internal capsule. This is the thalamus, and this is the lentiform nucleus. Then the coronal section. So in the coronal section, what we see here is the intrathalamic adhesions, which is in the medial boundary of the thalamus, the intrathalamic adhesions. And then the medial dorsal nucleus. This is the medial dorsal nucleus. So then the posterior part, that is the pulvinar of the thalamus. This is also called as the buttock of the thalamus, which you can see from the behind, the pulvinar of the thalamus. So why we should know about all these anatomies? So now we have discussed yes, I get some interruptions now. Can I continue?
Yes, go ahead, sir.
So it is important to understand. So why is it important to understand the anatomy and various connections of the thalamus is very, very vital to understand in the management of the thalamic tumors. So the thalamic tumors or any thalamic lesions, it's very, very difficult to manage. So whatever we have discussed is shown in this picture. So we have a lot of tracts connecting the thalamus to the various parts of the brain, which are all very vital, which carry vital tracts and information. So any lesions at this part is going to be producing significant neurological deficits. So we need to have a thorough anatomy of the tracts and the microneuroanatomy of the thalamus. And then the arterial supply of the thalamus, it is mainly provided by the posterior cerebral artery. My arterial supply is mainly from the posterior cerebral artery. So anterolaterally, the thalamus is supplied from branches from the posterior communicating artery, and laterally it is from the anterior choroidal artery, and posterolaterally it is from the thalamogeniculate artery, and medially it is via the thalamoperforating branches, and dorsally from the posterior choroidal arteries. So these are the main arterial supply to the thalamus. The arterial supply is also very important because in the management of stroke, the thalamic strokes is what is called as Dejerin-Rossi syndrome. So it is quite peculiar, where the thalamic strokes, the patients will have contralateral significant burning type of pain. They will have severe burning type of pain. That is what is called as thalamic strokes or the thalamic infarcts, which is called as the Dejerin-Rossi syndrome. It is a Puget's classification of thalamic tumors. So I'm not getting into these classification types, the Puget's classification. So what we need to know here is it's the application of the anatomical knowledge to understand the manifestations of the clinical manifestations of the thalamic lesions. So any lesions in the dorsomedial thalamus, so any lesion in the dorsomedial thalamus So what happens is the third ventricle lies between the two dorsal nucleus of the thalamus. So any lesion in the dorsal nucleus of the thalamus, so what is going to happen is it is going to compress the third ventricle, resulting in obstructive hydrocephalus. So any lesions involving the dorsomedial nucleus of the thalamus can result in obstructive hydrocephalus. And any lesions in the ventrolateral thalamus. So the lateral thalamus is related. So this is the ventrolateral relationship of the thalamus, where it is related to the posterior limb of the internal capsule, the lentiform nucleus, where the corticospinal tract and the motor fibers traverses. So any lesions involving the ventrolateral part of the thalamus, they can produce neurological deficit by direct compression or by direct tumor infiltrating the internal capsule in the form of contralateral hemiparesis or hemiplegia. And the visual symptoms. The visual symptoms, if you see that this is the relationship of the sublentiform part of the internal capsule with the thalamus. So this sublentiform part of the internal capsule carries the visual radiation or the optic radiations. So the optic fibers, they traverses through the sublentiform part of the internal capsule, which lies closely with the thalamus. And so this is the pictorial representation. So the involvement of the hypothalamus results in endocrinopathies, and involvement of the mammilothalamic tract of the fornices can result in cognitive function and memory disturbances. So this was a recent article. So this is the last part of our discussion today. So this was a recent article published by Ugur Ture, so which has completely changed the concept or the approach to the thalamus. So in the surgical point of view, the thalamus is the surfaces of the thalamus is classified as lateral ventricular surface. The one which is marked with yellow, this is called as a lateral ventricular surface. This is the velar surface, that is in relationship with the velum cavum interpositum, that is called as the velar surface. And then the cisternal surface, it is primarily the pulvinar part of the thalamus. That is the cistern which lies completely, the pulvinar completely lies within the quadrigeminal system. And then is the third ventricle or the medial surface of the thalamus. So this is the third ventricular surface. So he has classified the thalamic surface into lateral ventricular surface, the velar surface, the cisternal surface, and then the third ventricular surface. So based on the type of involvement of the surfaces of the thalamus, the approaches is being decided. So if the lateral ventricular and the velar surface is involved, the anterior interhemispheric transcallosal approach is preferred. If the cisternal surface is involved, then we go for the PEST approach, that is the perimedian supracerebellar transtentorial approach, or the PITS approach, which is the posterior interhemispheric transtentorial subsplenial approach. And if the third ventricular surface is involved, we go for the PEX approach, that is perimedian contralateral supracerebellar suprapineal approach. So finally, the direction or the displacement of the corticospinal tracts dictates the surgical trajectory to avoid tract disturbance and thus minimize the surgical morbidity. The presence of a large lateral ventricle makes the transcortical approaches to the ventricle easier. So that is why the discussion on the anatomy of the thalamus is very, very pivotal and vital. So these are rest other various approaches. Just I will be mentioning this for the sake of completion. Or the transcortical transventricular approach, the interhemispherical approach can be either anterior transcallosal or posterior transcallosal, and the supracerebellar infratemporal approach, the transsylvian transinsular approaches. So to conclude, the main thing which we need to remember is the lateral relationship of the thalamus, which decides the trajectory to approach the lesion. So the laterally it is related to the posterior limb of the internal capsule and the lentiform nucleus. And the various nucleus of the thalamus, which is divided by the Y-shaped lamina. So to summarize the connections, the anterior nucleus is responsible for emotional tone and mechanisms of recent memory, which forms a part of the paper circuit. The dorsomedial nucleus is mainly responsible for the integration of somatic, visceral, and olfactory information and emotional feelings. The ventral anterior nucleus influences activity of motor cortex. The ventral lateral nucleus also influences the motor activity and motor activity of motor cortex. The ventral posteromedial relays sensations to consciousness, and ventral posterolateral nucleus relays common sensations to consciousness. The intralaminar nuclei influences the levels of consciousness and alertness. The midline nucleus function is not clearly known. The one which has been mentioned is the centromedian parafascicular nucleus, which is mainly concerned with the ablative procedures in the management of motor tics in Tourette syndrome. The reticular nucleus, it is not clearly known, but the cerebral cortex regulates the thalamus with the reticular nucleus, because the reticular nucleus primarily has an afferent and efferent loop towards the thalamus. It doesn't have any efferents to the any other area. So it receives and it gives only within the thalamus. The medial geniculate body is primarily concerned with hearing, and the lateral geniculate body is mainly concerned with vision. So thank you very much for your patient listening, and thank you very much for the opportunity given. Thank you.
Okay, Ahmed, thank you very much. Ahmed, you want to take over?
First of all, I want to thank Professor Natrajan for this fascinating lecture. And also, I want to announce this opportunity for attendees to ask His Excellency any question. Okay.
Well, I'd like to just remark, I thank you very much for taking your time on a Sunday. A lot of kids don't realize this is your free time. You work hard all week. You have your office, you have your surgery, and you may have been up part of last night, yet you're still here to educate. And that's what I love about this community of neurosurgery. They're always ready to educate, always ready, even on a Sunday. Okay. Most of the times people are a little shy about questions and stuff. So don't be surprised. I think it'll take a while for people to get really comfortable. You know what I mean, Natarajan? It'll take a while for people to get comfortable. And Ahmed, it'll take a while for people to get comfortable and ask questions as they would in like a normal classroom. Unless someone may surprise me. Does anybody have any comments, or they want to just make a remark or a question? I certainly don't expect any. But yeah, you put this together quick. I wasn't expecting this when Ahmed called me, because we lost contact, right, Ahmed, for a while. My WhatsApp wasn't working too well. And when when that WhatsApp doesn't work, it's like you lose contact with the world. But anyways,
you're right.
Okay, I guess we're ready to wrap it up. And I'll end the broadcast, but you certainly will ready if you want to hang around and meet Ahmed and Natarajan off camera. You're welcome to hang around. Ahmed, what's the plan? Do you have any plans for the future? Ahmed, do you have any webcasts in the future?
Yes, we do, but we need, some time to contact other sources. Yemen Neurosurgical Society are planning to have an international conference with many neurosurgeons worldwide, and this conference will be streamed via Neurosurgical TV on May, inshallah. I mean, after maybe 4 months. Okay.
Okay. Starting early promotion, 4 months. Oh, well, that's okay.
Yeah, you're right.
That's good. And you're medically, Natarajan, Ahmed's a medical student, right? Last year, Ahmed, your 5th year, right?
Yeah, I mean, there are 2 years remaining.
Yeah, you seem to know social media pretty good.
Somehow.
You like it. You like the internet, right?
What?
You like the internet.
Yeah, actually, the internet here in Yemen is very bad, but we keep struggling in
No,
order
it's
to
a fact.
have.
No, you're using it effectively. You're using it effectively. I tell students that you push the technology. Don't let the technology push you. Push it. Push the
Mm,
technology. Try new things. Try different ways of doing things. But anyways, I'd like to thank you, gentlemen, formally, and we'll end the broadcast
you're absolutely correct.
and we'll just stick around. Okay, okay, Tower John, stick around. Okay.
Thank you. Thank you.
Yeah, I'm gonna end it right here. There, I gotta stop the recording.